Live.
No, we're not live. Can you hear well, Matea?
Yeah.
Okay, I
Okay,
think
because I couldn't hear you well, and I hope all can hear us actually.
No, it seems like you're on. It says live.
Okay, we're live, ladies.
all right. So we can see people joining. Maybe let's give it a minute or two. All right. Okay, should we start with introductions? Maybe Yulia, Vanessa, if you want to kick it off.
Yeah, absolutely. Thank you so much for having us on this webinar today. My name is Yulia. I'm the founder and CEO of Willbe. We are an online biohacking and health coaching platform. We specialize in female hormonal health during perimenopause, and we help women turn perimenopause into longevity.
That's a very cute cat. Vanessa?
Yeah, the cat is all good for the serotonin. So thanks, Nikolina. I'm Vanessa, a doctor. I have a PhD in longevity science, specifically into nutrigenomics. I am 48. I went into perimenopause a little bit earlier than what I was expecting. And yeah, just understanding how I didn't fit the mold. For me, understanding the link between genetics, biohacking, and how to really optimize my perimenopause journey has been quite difficult because it was uncharted territory. And yeah, I've really been enjoying working with Yulia. I'm the Chief Medical Officer, and I'm a big fan of glycanage, my test for my retest here. So it's great to be here and share our knowledge with all of your Glycan fans.
Well, thank you for coming. Maybe I'll also do a little introduction. So everybody calls me Nina, which is short for Nikolina, and I'm a co-founder. And this was, from a scientific perspective, this is, well, my father's life work. So it's 30 years of science. He's a glycobiologist, and he's been obsessed with this field since his, first lab internship when he was 20. So he pioneered the space and did the first large population studies of the human glycome, and then discovered this marker for aging, or to look at aging on a molecular level by looking at glycans on your adaptive immune system or your antibodies. And that's what we look today with glycanage. That's the test you have there. And maybe an interesting story around menopause. So we always saw different aging curves with men and women. So men would just age in a straight line. And then women had this curve where they would look more favorable to men. So their inflammation levels or inflammation would be lower compared to men. And then they had this rapid acceleration between age 45 and 55 on average. And at the time, we thought, okay, well, this is probably menopause related, but nobody understood actually, because all of our scientists were pre-menopause, they didn't understand how menopause happens. So when we got our first commercial clients, we would see this in their glycanage. So they would go from a pretty good glycanage to an increase of 10 years within a couple of years. And then we would ask them a question of, oh, could this be related to menopause? You're 45, but we usually see this with menopause. And then they would tell us, no, I have a perfectly regular cycle. I'm not in menopause. And then we learned that what we're actually seeing is perimenopause, or this drop in estrogen that happens before your cycle stops. Because the drop, you can still be cycling for years and years and sometimes up to 10 years, but because your overall estrogen has declined, you have all the symptoms of perimenopause. And that's when you start to go to your GP and complain about sleep or a range of 100 different symptoms, and usually get something for the symptoms, but you don't get something for the cause. So you go in with sleep problems and you get a sleeping pill, or you go in with low mood and you get antidepressant. There was a statistics in the UK where 66% of women who had come in with menopause related or perimenopause-related symptoms will be given an antidepressant instead of estrogen. So it's a big problem. This kind of detecting perimenopause is a big problem, and then also getting access to the right therapy. So your story is not unusual. It's almost every single woman, and that's insane because it happens to all of us, and we actually know very little about it.
Yeah. And that was also a really good opening of our webinar, because it's really important to understand what problem we are discussing today, why we're talking about female health, especially during perimenopause, because female health is really under-researched. Women were not included in medical research until 30 years ago because of our bodies being two variables, because of our hormones and our cycles. And this has left women unsupported, underdiagnosed, with limited options. And in fact, there was a recent article which was published in Nature magazine in February, which discusses that there is a critical knowledge gap in the medical community about female hormonal health beyond reproduction. And will be tackles this massive gap which exists in medicine by helping women to go through perimenopause, because we believe that perimenopause is the biggest opportunity for longevity. It's that time of transition when everything changes for women. And what we hear from our clients in the clinic, that yes, women experience symptoms and they don't know where to turn, but what they all say is one statement: this is not me. I have no idea what is going on. Things that were working for me 5 years ago have stopped working. And this is really, really important problem to solve. And I'm so glad that we have this opportunity to discuss and to define how we can define what proactive gender-specific care looks like, and showcase the transformative approach that Wilby and GlycanAge can have when we approach perimenopause with a different mindset.
So maybe to focus on the two problem areas. One is identifying perimenopause, because maybe Vanessa, you can talk about from the clinician's perspective what tools we have, what we're missing. And then the second topic is treatment. What do we have, and why is it not as used as well as it should be? So Vanessa, I leave it to you.
So I think, and I think there's a big movement. There's a big movement in society at the moment. I think we have a lot more thought leaders in both America and the UK who are really driving the menopause and perimenopause conversation forward. And I think women, if I look back in just a 5-year trajectory, the discussion on symptoms and making it less taboo, I think is serving us in our favor, and it should be something we have access to. A lot of the diagnosis for perimenopause is on symptoms. The challenge, though, is that often the first hormone that actually normally declines is progesterone. And it is very subtle, and it's not as overt as when you get to the estrogen drop-off, which happens kind of in the second part of that perimenopause phase. And a lot of women spend anything between, I think the statistics, also UK-based, is anything between 2 to 4 years in trying to get a clinical diagnosis of perimenopause. And they also are suffering up to 7 symptoms of perimenopause each. So it's taking a long time, and they're suffering, and they're not getting the answers. And like you said, they're getting segmented symptom solutions, not root cause integrated support in assessing it's actually a hormone imbalance. What are we going to do about that? Are you a candidate for BHRT? What is the right, how do we address that? And a lot of people have got very different views. Also leading up to that, I think most women are aware that there was quite a flawed study, the Women's Health Initiative from the 1970s, and that put a lot of people off going on hormone replacement therapy. different conversation and part of, what treatment do you choose. Testing and treating. So now a lot of it is based on symptoms. At Wilby, though, we do have a slightly different view. We don't believe that you need a blood test because a blood test is just an instant, but we are looking at urine markers. And the reason for that is we want to go into the metabolism and look at how your estrogen pathways are. We know that there are certain pathways that can reduce your risk of breast cancer. Those estrogen metabolites also reduce your risk of heart disease. And so when you look at what happens, that trajectory of health after perimenopause, we know that our risks as women of cancer, cardiovascular disease increase. And that's because we lose that protective estrogen metabolite. And so we want to assess that. So we're not looking to diagnose, in our testing, we're not looking to diagnose perimenopause, but we want to see what is your body doing so we can give you the right tools and then treatments. And also what we're doing is we are looking at genetics. So we have a product called FemGene, and there are not a lot of products in terms of genetic space that look at women's health and actually look at estrogen and the loss of estrogen as an epigenetic player. So when I talk about epigenetics is we think we lose estrogen and that's it, but actually it impacts how our genes express. And so the woman that goes in with anxiety, that can be as a result of a gene that is actually, there's not enough estrogen and that gene isn't now expressing as well as it should. And you may be getting anxiety as a result. So we're trying to really close the gap between, what's happening at hormonal level, including thyroid, which also comes into play, and insulin, but also looking then at what happens at genetic level, because we can also help to push those positive estrogen markers. We can also help to weigh them up. And from that assessment, we then look to see, okay, right, let's, do we want to add in things? Do we want to look and see what is your longevity view? Are we going to look at glycans and look at the glycan age testing as well? And then from there, we can actually give somebody a holistic integrated plan and say, this is what you need to do for your detoxification. Yes, you would be a good candidate for hormone replacement therapy. Actually, if we give you hormone replacement therapy, you could actually increase your risk of that. I don't want to say harmful because estrogen is a natural and we need it. But when we have got certain metabolites in excess ratios and percentages, they are linked to, increased risk of disease and DNA damage. So how do we prevent that? What are the strategies? There's a lot of things, lifestyle orientated, that we can do to make sure that you've got safe, effective symptom relief, whether it's through hormone replacement therapy or not.
So maybe then I think what you're talking about is this personalized approach to menopause care, because it is, although we label it as one thing, it presents very differently in different people. And as you said, it's 7 symptoms per woman, but there's almost 100 different symptoms of perimenopause. So how you're going to experience is going to be very different to me, to somebody else. So when we look at the clinical guidelines, there's not much there that a clinician can work. So symptomology is the main criteria, but there's no test for it at the moment that's recommended in the guidelines. And menopause is technically a retrospective diagnosis. So officially you're diagnosed a year plus a day that you haven't had a full cycle. And this could mean that you have a cycle for 2 months and then it stops again and you have to wait a year until you're finally...
It could take you up to 10 years to get that diagnosis.
Exactly. And the medication... Yeah, sorry, go ahead.
No, I just said, who's got 10 years to wait? We're women, we've got a lot more things to do with our lives than wait for 10 years for a diagnosis.
It makes absolutely no sense. And I think that's also the reason why, there's many, we'll go into treatment second, but the labeling on HRT is postmenopause. So technically only after this point does it say in the guidelines for you to go on hormone replacement, which means that there's years and years of suffering before somebody working alongside guidelines is actually going to give you the right treatment.
And hormone replacement therapy is not even indicated. It's only indicated, and I'm not going to quote it, but in the UK, I know we've only got 2 symptoms. There's only 2 symptoms that is actually indicated for, and all the other symptoms is actually, it's not under the recommendations that it's actually used to help manage those symptoms. So that is why women are being given antidepressants when actually they should be supported in neurotransmitters, which is what the brain needs to feel happy and feel good.
So we currently don't have the right guidelines for menopause care. I think that's fully agreed. And then we can see this in the the amount of suffering that women go through at the moment. And I think the first misconception is we should be measuring estrogen in blood, or we should be measuring your hormones. And one complexity we have there is that, again, your level of estrogen is very individual. So this reference range is from 65 to 350. And normal is anywhere between that. And you usually don't have a baseline from your 20s or your 30s. So when you're in your mid 40s and you've dropped from 200 to 100, if you're looking at estrogen, your clinician would say your hormones are normal. There's nothing wrong with your estrogen. So and then as you said, perimenopause actually starts with progesterone decline. So you don't need estrogen yet for a period of time. And then there's a cliff, which is actually when we believe that the glycans, because the glycans we look at for menopause, they're regulated by estrogen. So we're actually seeing this estrogen drop in perimenopause, but the period before you could have a progesterone drop, and that the treatment will be different then to when you actually need estrogen. So maybe as you've gone through this whole personally, I don't know if you want to share your journey and how you identified it and what you did, if that's an area you want to go into.
I mean, I can do, because I think it's always useful for people to understand. And I think that's where Wilby comes in with a personalized approach. I went on to hormone replacement therapy, and it was kind of your standard dosing as recommended. Nothing wrong with that. But the reality is that we're also individual, and your genetic profile has a significant impact on how your body manages your estrogen. When you even go think back to pre-menopause or anything, why do certain women suffer with PMS, and why do some people not? Why do women have such diverse responses to a menstrual cycle? And a lot of that is governed through their underlying genetics and lifestyle. Now you've also got now we perimenopause going into postmenopausal. Of course, we're going to have certain and different reactions, and it was terrible. It really didn't work for me, and I had to really go back and dig deep into going, why isn't this working for me? Because yes, I had early onset perimenopause. I started probably around 42, and I also then had anxiety issues and attention issues, which were masked because estrogen is great at sorting those out. And this is also why when we hit menopause and perimenopause, we are seeing so much of the neurocognitive issues coming in, the neurodivergency, and the late diagnosis of things like ADHD and anxiety. And that comes down to your ratios of your estrogen and your progesterone. And not everybody is suited to a standard dose. And that's what I was given. And it took me quite a while to realize that I needed to go in softly. That is what worked for my body. At the same time, I was doing my other testing, and I did more on my genetics, and then I found out about the COMT gene and the methylation. And this was 5 years ago, before methylation was such a big thing. But I am not I don't process dopamine well, but COMT is also involved in your protective methylation of that protective estrogen metabolite, but it's also impacted in things like attention and anxiety. And once I realized that, and then I started adding in my methylated B vitamins, but again, just small doses, I then managed to get myself onto a more bespoke hormone replacement therapy, but obviously bioidentical. And that really helped me to just kind of find that sweet spot where actually I'm thriving again. I'm not struggling against life. I have a personality back. I'm not snapping at my kids. I'm actually able to engage with things. And it was quite incidentally that I then met Yulia at kind of the end of that phase when I had kind of figured out my solutions. And I thought that's just me. But what we've come to realize is that there are so many women who are given the best care that their provider is able to give them, and that is the, standard, patient care protocol. But it doesn't always fit, and it doesn't work, and they're frustrated, and that's where we have the opportunity to really step in. And I think there's, I can relate because I've been through some sort of a journey. And I also know that I have to be careful because we have things like osteoporosis in the family. And I can tell you hand on heart, my genetic profile is one of the worst I've ever seen in any of the clients. But the proof is in the pudding, because in spite of that, I have done everything in my power. And whilst at the time it was frustrating to get such a negative genetic profile, because that's my love and my passion, I fell in love with genetics when I was at school, so I can relate to your dad's passion about glycans. And yet my blood work, my bone density, all of those parameters that should be negative, they aren't, because I'm empowered to actually take control and put the necessary steps in place, whether it's through biohacking, testing, staying on top of my diet, exercise. And so there's always solutions, there's always ways to feel better, whether it's psychologically, how you look, and also like a biochemical genetic level. We can always do something to help women. And I think that's one thing I want them to take away from today.
And this is a prime example of how personalized healthcare works, also gene-based healthcare, based on the example that Vanessa just shared. And it's important to realize that your individual biology should be the single overriding factor in the way you're treated. And women should be empowered with knowledge on what is going on inside. They need to understand how their estrogen is synthesized, the sensitivity of their estrogen receptors, how they clear estrogen, do they have the tendency to anti-inflammatory estrogen metabolites or pro-inflammatory estrogen metabolites? What is their suitability to bioidentical hormone replacement therapy? Because your genes actually dictate how you will respond to bioidentical hormone replacement therapy. So current testing, so actually Dr. Vanessa mentioned FemGene. This is actually the problem that we saw with the clients that we had over the past 2 years. While we are very fortunate of having access to many different biomarkers, there always has been that missing link. What is driving those menopause-induced symptoms? And Dr. Vanessa, she dove deep into understanding how declining hormones influence gene expression and what is the connection between genes and hormones. And she actually created the first genetic testing, which looks at meaningful SNPs for a woman that is going through perimenopause and menopause. This allows to give us clarity to women on why they're experiencing certain symptoms, how to fast track symptom relief, how to pick the focus area for longevity, being bone health, brain health. And what I really like about glycan age test is that we can actually see how if estrogen replacement therapy is working as a longevity medicine for you. But I want to get into that conversation after we get over the misconception that estrogen is to be feared. Yeah.
Let's maybe then start on this topic. So I think now over 20 years ago, the WHI study was published, and before the WHI, and this was, I think, up to now, the biggest women's health study
Yeah.
ever. Billion invested in a big women's health study, and it actually caused a lot more harm than good to a whole generation of women. And before the WHI, estrogen use in the US was 40%, and I'm not sure about globally, but that was as it should be. Let's say that that's a good proportion. Today it's 4%, and majority of the impact is that study. Now, the data was hugely misinterpreted when it was published. It went to the media before it was officially published, and there was this scaremongering of the potential harm of the at the time type of hormones, which were synthetic. And they mainly emphasized on the breast cancer risk, which was just about above statistically significant. So I think it was 1.26. So it just about met the criteria. And even when they looked at data later and they looked at breast cancer, women on HRT who get breast cancer actually have a reduced mortality risk than women who are not on HRT. So we know that that breast cancer story was a completely false narrative. And if they looked at the estrogen alone arm, there was no increased risk of breast cancer. So if the risk there was probably the synthetic progestogen. So HRT was hugely misinterpreted as something that's a risk factor, that there's more risk than benefit. And now, because the drug has been in use for 40, 60 years, we finally have the long-term outcome data. And the long-term outcome data came back incredibly positive. So if estrogen started early, around the age of menopause, there's a 40% reduction of all-cause mortality for women which are on it versus not on it. So beyond, and this is what we see reflected in glycan age, we see a significant acceleration of aging, about 10 years on average, as you transition to menopause. And we see a deceleration of these 10 years if you go on estrogen. So we see this impact of overall risk of morbidity and mortality for women that go on it versus don't go on it. And there is a personalization side, and we can go into it.
Yeah.
But all the data now is pointing to that estrogen is a longevity drug. And it's probably the best and the most validated longevity tool we have, that we should be applying to a good proportion of women, and only about 4% of it actually have the benefit today. So maybe Vanessa, if you want to touch on that a bit.
I think there is a lot of hesitation, and I don't want anybody listening to think that we are pushing hormone replacement therapy, but and there are women for specific subsets who cannot take estrogen or any hormone replacement therapy. They may have hormone related cancers, and for them, we do have other strategies to help them. And not everybody feels comfortable. And I think a lot of this has been from the conversation also that menopause is natural. And that's fine. And for some women, they do go through it and they don't have debilitating symptoms. But when you look at the number of women that are suicidal, when you're looking at the women, 1 in 7 women in the UK will leave their job because they feel so inadequate for multiple reasons. There is a good case when it is that debilitating to be looking at that as a potential answer. And so, yes, so hormone replacement therapy is fundamentally safe. I was also caught up in the narrative of it's bad. And I had to really also then re-educate myself, as well as the estrogen that we are using is bioidentical. We are titrating it, we are managing it. And because of that, there is that sense of surety. We know what we're doing, we know the pathway we're going down, we know that we are providing women with a safe, effective treatment at the minimum dose. And not everybody is responsive to the same dose. Some people only need a little bit, some people need a lot more, and there's been a lot of kind of exposés on how much do you need. And that's where the urine testing, when we look at the metabolites and which pathways you're going down, will actually direct us for personalized care. Sorry, I don't know if that answers your question.
Well, we're mainly making the case for the benefits of estrogen, or
Yeah.
let's say
Yeah.
hormone replacement in general, because it's not just estrogen alone. Some symptoms
No,
relate to
you do
progesterone.
need to balance, and that's the thing is, as women, we have multiple hormones in our body, as well as progesterone. And another misconception is that if you've had a hysterectomy, so you don't have a uterus, there is also the belief that you don't need progesterone, and that's often also in the guidelines. And the reality is that progesterone is there to balance the estrogen, but it also has a lot of positive effects in your mood and especially for sleep. So a woman who has had a hysterectomy is often not offered progesterone because they don't need that protective balancing out of the endometrial lining that estrogen does. So you use the two to balance each other out, but they're also missing out on so many benefits. And that's also quite frustrating sometimes when women are not getting the hormone care they need during this time. And progesterone is the first one to go. And it's actually the more subtle one and the one we don't talk about, because we only get to the estrogen part of the conversation when your period actually starts to change. And by then you've already suffered 2 to 3 years with low progesterone. And that's quite negative when you look at sleep and the impact it has on cognitive function and how women actually do accelerate into that area of Alzheimer's and dementia post-menopause. Our risks increase. So it is important that we look after sleep, because that's when the brain, sorts itself out. We make memories, and also it recovers from the day from a biochemical point of view and detoxifies.
So I think what you're saying, there's no easy solution, and there's no one size fits all. And I think on the sleep side, we have a board member. She also went into perimenopause early and was kind of hesitant to start HRT, and she didn't sleep properly for about 7 years, and in a number of quite severe symptoms. And then when she started it, she called me 2 weeks later saying, "I'm sleeping." So I think if she knew the effect 7 years ago, she wouldn't have put herself through the trouble. But it was really this anxiety of potential risk factors. So taking in everything you know now about the risk and benefit, and also taking into account that, hormones are something we naturally have. And now we have body identical hormones who mimic or match the type of molecules we naturally produce. What is this risk-benefit ratio, or what do you think is the proportion of women that should be thinking of? And keep in mind, we're again treating aging. So you have this debate that was very controversial 20 years ago, where we shouldn't treat aging because menopause is a consequence of aging. And now you have this rapid shift in the market where we're talking about longevity, and we want to treat these mechanisms of health decline before they actually turn into disease, or we want to treat aging. So what proportion of women do you think should be replacing their hormones versus living through the shift?
So without looking at any sort of society pressure or own internal pressure, and just looking at the clear kind of the statistical analysis, I think that all women should be looking to supplement their hormone levels, especially unless there is a medical condition like estrogen or progesterone receptive cancer. So the cancer community we need to take offline. There are still certain supports, so things like vaginal estrogen for dryness and libido can be used once they've been cleared through. It's not systemic, so there are things that can be done to support them as well. But I think anybody who, especially if there's a risk of cardiovascular disease, dementia, osteoporosis, or, just that feeling like they're not well, then that's pretty much, I think, all of us when we're hitting our 60s and 70s. I think that every woman should, at least, even if they choose not to do it, be empowered enough to have an intelligent conversation and also be presented with their personalized facts, whether it's looking at glycan test for their aging, looking at biological age, what is the inflammation. You've got the glycan mature marker that you specifically use to identify perimenopause and the impact of hormone replacement therapy, and then looking at genetics, and then how your body's actually metabolizing your all your hormones. So I say estrogen, but it's actually, we look at progesterone as well, testosterone, and then to actually then be presented with that in a way for women to then say, you know what, yes, this is something I want to pursue, or maybe not. And that's completely women's choice. I don't ever want them to think that they don't have that choice, but just do yourself the favor of taking the time to understand your body and make an informed choice. Because whatever choice you take, amazing. But let's be as informed as what we can.
Yeah.
Yeah. Can I just add to that it's really important to overcome fear of estrogen and hormone replacement therapy, because as we know, there are so many claims that estrogen causes cancer, and the word hormone in general has that negative connotation, almost becoming a swear word. But we should ask and understand, where did that fear come from? Like, what is happening? And you don't need to be a medical professional or have a medical degree. You can just use your common sense and knowledge to understand that estrogen doesn't supposedly cause cancer. And the first problem when we are discussing estrogen that we encounter is the problem of terminology. So whenever someone claims that estrogen causes cancer, the natural question should be, what type of estrogen you're talking about? Are you talking about the estrogen that is produced by our own bodies, E1, E2, or E3? Or are you talking about synthetic estrogens, which is in birth control pills? Or are you talking about Premarin that was used in the infamous WHI study? Or are you talking about bioidentical estrogen? Or are you talking about pseudoestrogen that we get from perfumes, environment, and cosmetics? What estrogen are you talking about? Is it the synthetic estrogen that is causing cancer, or which one? And let me give you the analogy. It's like saying if chemical laden Haribo's cherry candies cause ADHD in children, does it really mean that real cherries are bad for you? And next, let's think logically. If when do breast cancer rates arise? In which demographic group? In demographic group which are estrogen deficient states, those women that are going through perimenopause, menopause, and postmenopause. If estrogen really caused cancer, then we would see a high rates of breast cancer in younger women, in pregnant women, when they
Pregnant women. Yeah.
So this is the school of thought that we need to get around, and this is again changing the mindset. I'm trying to bring this conversation more to changing the mindset. There is a need to change mindset that perimenopause is not the decline. Perimenopause is not the transition that we need to push through. Perimenopause is the biggest opportunity to optimize your health and longevity, because when you leave your body in a state of hormonal deficiency for too long, it deteriorates your body, because on every single organ in our body system, we have estrogen receptors, and our organs require optimal estrogen levels in order to function at optimal state. So is it logical to say that the hormone that we are producing and we are relying on as women can cause cancer? This is just simple thoughts that should arise in people who think critically, and most importantly, think independently.
So I think this is building off of that false narrative that's been there for 20 years that I think, unfortunately, most clinicians have bought into through time, and there's been a lot of advocacy recently, so I think we're moving in the right direction. But I think this is our narrative, and Yulia, I believe you are on the same mission to show hormones, and for us, we see predominantly effect of estrogen. We haven't yet done testosterone studies, for example, but it could be that we see the same from that in women. And we do see benefits of testosterone in men, but it's really the conversion to estrogen that would drive the anti-inflammatory glycan shift. It's presenting this as longevity intervention versus something you have to choose if your symptoms are severe enough and if you're close enough to menopause. Actually, it's something you can proactively preempt and get to know your body from a genetic to a glycan level in that period, and then optimize for it for a long-term health outcome, which has nothing to do with the symptoms or the decline. It's really this kind of longevity initiative, or making it something that's very positive. So maybe if you want to share a bit more about the mission of WellBe and where it came from for you,
Well, it's actually about empowering women with knowledge about the way their body work, and it's also about positioning diagnostic testing as a tool to optimize health, because there is a misconception within the medical community that too much data, too much testing overcomplicates the care and overwhelms the patients, which is not true. So much data helps put patient-centric, very personalized protocols with very personalized interventions, improving patients' outcomes. And what I really like about GlycanAge, that GlycanAge can actually show us if bioidentical hormone replacement therapy works for you as a longevity medicine by looking if the systemic inflammation is reducing. Because again, hormones govern female body. When there is a decline in hormones, women risk for cardiovascular disease skyrockets, and or not just cardiovascular disease, the risk of Alzheimer's and everything. And it's really and declining levels of hormones also have a play in atherosclerotic plaque formation, which is caused by systemic inflammation, right? Yeah, like this is that holistic approach, but most importantly, empowering women with understanding what they need to do. So what priority area for longevity they need to pick, not to pick, but to identify, and to give women that clarity, what is driving those symptoms at an intensity felt of 8 or more that we hear from our clients, and how to solve them, how to fast track the problem. As Vanessa mentioned before, women spend 2 to 4 years on searching for solutions, and also they spend around £2,000 in the first 18 months on the same thing, and they're not getting clear answers. And when they come to us and we look at their genes, and Dr. Vanessa is an expert for matching genes to other biomarkers and explaining, she's actually draws a really cool mind map, like what is triggering your symptoms. Like it helps women understand what is causing the symptom, what do they need to do, and it actually helps them to stay more compliant with the implementing protocol that we are giving. So I actually think we are on the same mission. Our mission is about prevention, and perimenopause, again, is the biggest opportunity for longevity when prevention becomes possible.
Amazing. Maybe then I'll just share on the glycan perspective of what it actually is. So we look at the glycan composition of your immunoglobulins or your antibodies. And actually, a majority of chronic disease has a similar cause or a common mechanism. And it's this low-grade systemic chronic inflammation. We think of the immune system sometimes only as like a response to infectious cause, but actually it's this accumulation of damage to our immune system, or this low-grade inflammation that would turn into cardiometabolic disease, or we would not be as efficient in killing cancer as it used to when it was younger, or you would overreact and turn into autoimmune disease. So it's one system that kind of governs a whole cascade of different disease, and that's what we see shift in the menopause transition. So really all of these risk factors that you were protected from pre-menopause, actually, and that's what you see in the increased risk of morbidity and mortality in women post-menopause who are not replacing their hormones. So it's a crucial factor. And the one we are customizing to clinical use is this, we call it glycan mature for simple naming, but G's zero in the scientific papers. And it's this very pro-inflammatory structure, which is in part regulated by estrogen. And what we're actually seeing is that you have homeostasis in the period before, because your estrogen is at your normal range, which is wherever in this reference range, and unfortunately usually don't have your baseline. So then as estrogen declines, you lose homeostasis and inflammation goes up. And then when you start therapy, you don't know what dose. So this is a tool to help a clinician titrate that dose to a patient. So the decision as we're making, we're helping a menopause specialist, or hopefully one day even your primary GP make, is when do you need estrogen in perimenopause and how much estrogen is the right dose for a woman. And I think then combining that with your solution, where you look at the genetic component and you incorporate it with other hormones, you can really get a comprehensive view on what would be the right approach for an individual woman. So I don't know, Vanessa, if you want to touch a bit more on the approach you use in practice, so where you start, where you want to end with a client, and then there's a lot of questions coming through, so maybe we can pick up some of these.
Sure. So obviously with us, we start with a deep dive. We're looking at your pathway. So we're looking at metabolic health. We also do a blood spot test because we are looking at thyroid. The thyroid is often not really assessed very well, but I would say that unfortunately the thyroid in 50% of cases is also not optimized. And the thyroid takes a knock as well. You know, our hormones are, you know, very, you know, just like you said, the immune system is very interconnected with the whole cascade. I call it your hormones it's a symphony. And the minute you've got the violin playing out, the trumpet's not going to sound right, and the conductors miss the beat, and it's all just a cacophony instead of this beautiful symphony. And so we have to also bring in the fact that we have insulin. Our hormones don't work in isolation. And so when you've pulled one out, so we do the blood test, we do a blood test to test thyroid. And then we also do the genetics. And the one for, you know, as this is why we're on the call, is we've obviously been discussing the role of glycan age and how that can also then help women take it to the next level. So we're looking at, you know, what is your longevity? How is this impacting you? How is our, you know, what strategies, whether it is lifestyle, you know, and then looking to see, you know, what do we need to implement for you? Do you have, you know, not enough pregnenolone, which is a metabolite of progesterone, which is the calming one. It's the one that releases GABA. A simple thing like somebody's got locked jaw and completely tense. That actually tells me that there is a risk factor that your locked jaw is coming from low progesterone because you don't have enough GABA for tension. And so people are going to dentists not realizing that this lockjaw is actually low progesterone. And so we try and look at them holistically, your symptoms, your blood, your urine, your genetics, and then formulate their individual plan. Where are the overlaps? So I like to mind map in certain clients when things don't follow like a normal path because everything is so interconnected. And then from there, say to them, look, you know, maybe it's their gut health. You know, part of our detoxification in the liver is actually triggered by what's going on in the gut. We have genes in the gut that actually tell the liver what to do. And so, you know, do you need to have a gut protocol? You know, are you going to the bathroom sufficiently enough? If you're not, you're going to be reabsorbing estrogen. You're going to be in an estrogen dominant state. And really just trying to map it out from, you know, from a kind of very obvious, are you going to take hormone replacement therapy, to how can we optimize your genetics so that we can get those urine biomarkers beautifully in line so that everything is safe and effective. And then also then layering, what is your longevity? So we look at things like bone health, we're wanting to encourage DEXA scans, and thermoscans, and all of those sorts of other aspects are available so that women can be very proactive, because when we're proactive, we can do so much more than when we're trying to be reactive. And building then in, what is your biological age? How is that going to help you? Is there more that we need to do? And we do focus on a very anti-inflammatory, low detox protocol in terms of our lifestyle nutrient recommendations.
Amazing.
Proactive and specific care.
Amazing. That's incredibly comprehensive. I think I'll become a client. So I have quite a few questions. Should we start going through?
Oh, yes. Yeah, let's go.
So I can read them out if you like. The first one is it's a good one. How different is body identical to bioidentical apart from cost?
So they're actually really the same. The one is more regulated in kind of your pharmaceutical industry. And the other one is generally your bioidentical is coming through from the more compounding pharmacy. At the end of the day, a good compounding pharmacy that is self-regulated, that is registered, with the medical authorities, is going to provide you with high quality hormones that are titrated exactly to what you need, rather than perhaps something that is a stock standard that may work for a certain population, but is not appropriate for you. I think that body identical versus bioidentical gap has closed in recent years. And there are a lot of very reputable companies around the world now where we can get safe hormones. And the cost does increase, obviously, because it's personalized. So yes, but I think also looking from when I started my hormone journey to where I am now, I have seen personally that the costs are starting to become easier as more people are adopting and going in for more compounded pharmaceutical prescriptions.
Amazing. So then there's another one. What are your thoughts on adrenal dominance? Also, how adrenals can impact perimenopause symptoms if stress is high and then progesterone drops?
Yeah, so the HPA axis, so the hyperpituitary adrenal axis, we also do assess that. We look at cortisol. Cortisol is something that does impact your body's ability to deal with stress. And we think of stress as just situational, fighting for a park, or something going wrong, or having an argument with the bank for whatever reason. But the reality is that we have internal stress and in that sense of anxiety. And so cortisol, we do have a look at as well. It affects our sleep. If progesterone is low, as I said before, that will impact GABA. GABA is your relaxing neurotransmitter. We need it to feel calm. We need it to feel to sleep well. And so that has an interlink and a balance and a ratio. As well as when you take away estrogen, you may then have that negative impact on the epigenetic impact on certain genes. And those genes may also then increase your sense of anxiety. And you may not present with anxiety, but that may actually be perceived as stress. And interestingly, that's what I had. I thought I was just stressed out, but actually I didn't realize, because I'd never had anxiety until my late 40s. But I was actually having huge anxiety. And it was only when I sorted out my estrogen levels and my genetic nutrients, did that calm down. So, and also progesterone, there are multiple touch points, and it's difficult to answer these questions because I only have like one snippet. And so just, in context, I need to do the deep dive. Okay.
Yeah, Stress should be another topic, but we, for example, official PTSD diagnosis gives you 15 years extra on the glycan age clock. Menopause usually gives you about 10. So stress or chronic status
Yeah, absolutely.
is worse
Stress
than
is the killer.
menopause in
Yeah,
terms
yeah.
of longevity. But that's a topic for another day. We have a few more. So what's the possibility of creating a baseline in your 30s? So hormone baseline, and which hormone should you get measured? And is it supported by healthcare at the moment? That's
Probably not supported by healthcare. Even now, women in perimenopause and menopause are suffering. We're not seeing them being supported sufficiently. And so a lot of the work that we're having to do is unfortunately falling under the private healthcare sector. If you are wanting to do a hormonal baseline, you're wanting to track your hormone levels at between day 19 and 21 of your menstrual cycle if you have a normal 28 to 30-day cycle. What you're looking for is you're looking to test after ovulation. You should see the corpus luteum on the egg that's released should then release progesterone. Your progesterone spike hits at that 19 to 21 day window. When that egg isn't fertilized, progesterone drops, and then we have our bleed or the menstrual cycle. And so when you test in that window, we are trying to see how much estrogen have you got and how much progesterone have you got, and what is the ratio between the two. That is fundamentally the hormone baseline that you're wanting to assess. And I would also say in there, get your thyroid, so your TSH, and then either total or free T4, T3 to see what your thyroid level is. There are a lot of other hormones, so but those, estrogen, progesterone are fundamentally the two. And then your thyroid is just always good to have in case, there is something happening from an autoimmune, it starts to drop off. People don't realize that the thyroid is really important for your sense of well-being and energy.
absolutely. So a good one, maybe Yulia, you wanna grab this one. Where can they find more information about the FemGene test, and do you have any sample reports?
Yeah, we do have sample reports. We also run complimentary discovery calls, mywillbe.co.uk or mywillbe.com, support@mywillbe.com, or you can find us on LinkedIn or Instagram, and we're happy to set you up for a discovery call, send you a sample report. Actually, a very interesting new thing that Vanessa is doing. We're providing training for aesthetic medical practitioners on personalized healthcare because there is a massive gap in knowledge on genetics. So if we have any of the doctors or health practitioners interested in genetics training, we can also provide that. Genetics on female health.
Amazing. And then there's one asking, how can I get on the hormone measurement program?
So that would just be to contact us at mywillbe.com. Yeah.
Maybe, should we put some links in the chat? Just so
yeah, sure. Let me just quickly.
Let's do that. All right. Okay, I can see actually in the other chat box there are more questions, but we're up to time. How are you doing to answer a few more, or should we try and follow up on email with these?
Yeah, some of these are quite involved. I'll answer the one from Susan. She said, after menopause, cholesterol went up. That's quite normal to see. Happy to live with her high cholesterol, but she's recently introduced testosterone in conjunction with estrogen, progesterone, and her cholesterol levels have gone down. And so I think what's interesting is your liver controls your cholesterol levels. And your testosterone, it comes from pregnenolone, and pregnenolone is made from cholesterol. And so if you actually don't have enough cholesterol, you cannot make your steroidal hormones, which is what all of our sex hormones are. And so when we look at the testosterone can actually tell the liver to calm down because it's one step higher up. So you've got cholesterol, pregnenolone, testosterone, and DHA in between. And so sometimes by adding in testosterone, you get increased muscle mass. That can be a benefit. And testosterone actually helps the body in certain women, not all, but in certain women, having a little dose of testosterone actually helps to absorb and have the benefits of estrogen, because again, testosterone, we actually make estrogen from testosterone, so we need lots of testosterone. And so sometimes by just boosting it, we actually can see a positive impact, not just in cholesterol levels. So yes, that could be potentially what is going on there.
So this is actually what we see with men. So if they go on testosterone replacement, we see beneficial change in glycan age, but only if they don't block aromatase. So if you use the aromatase inhibitors and you knock their estrogen down to 0, there's no beneficial effect on glycan age. While if you allow this conversion to estrogen to happen, then you see a very positive anti-inflammatory
So that's the estrogen kicking in. So just for listeners, the gene or the enzyme that converts testosterone into estrogen is called aromatase. And so often when there is excess estrogen, sometimes in estrogen receptor cancers, they will actually block aromatase so that we don't get any estrogen made in the body from testosterone.
Yeah,
and we can influence it. We can also influence it. So if you've got lots of testosterone, but you're not making estrogen, we can see that. We can look at your aromatase gene, it's CYP19A1, and we can, there are certain nutraceuticals that we know will actually push or pull it down, and to try and influence the direction we need it to go in.
Amazing. I think we definitely should have one webinar just on testosterone in women, and maybe also PCOS and
yes, endometriosis. It's all interlinked. Obviously, it's a younger audience than the perimenopause, but definitely.
Amazing. Okay, so let's try and keep it up to time so we can wrap up here, and then we can get some feedback on topics for next time and dive into another area.
Cool.
Sounds great. Thank you so
Thanks,
much.
thanks.
I will
Nina,
just
thank you
jump
very much.
in for a second, just to give the attendees attention for the message we were sending. So basically, once again, thank you all for joining. And in the light of approaching International Women's Health Day, we hope you enjoyed this webinar. We also shared a discount code of 30% that you are actually first ones to get before we share it with the wider community for International Women's Health Day. And I have attached also the link and the code in the message. Thank you so much.
Yeah, and happy International Women's Day, everyone.
Yes. Yay. Okay for us.
Women rock.
Amazing. Thank you very much. Thank you for everybody's time.
Thank
See you
you.
next one. Take care. Bye-bye.